Hi, and welcome to the May 1st, 2013 Plastic and Reconstructive Journal Club, coming to you from St Vincent's Hospital in Sydney. My name is Damien Marucci. I'm a plastic surgeon. This is Dr. Alice Chang, who's one of the plastic surgery registrars. So, Alice, today we did the 4 papers as usual. The first paper we did was the update on negative pressure wound therapy, which is actually from 2011 PRS by Orgill et al. Out of Boston, Massachusetts. So in a nutshell, what was this paper about?
This paper was a summary of the most recent articles published on negative pressure wound therapy, and it summarises basically 67 peer-reviewed articles. It showed that blood flow in wounds has a decreased blood flow close to the wound, but the flow of the blood further out is improved, and this is shown using laser Doppler. That show there's no difference in blood flow whether or not you use foam or gauze-based dressings. Fluid removal, there's actually no current data to show exactly how fluid removal improves wound healing. There's a couple of possible effects of micro and macro deformation, although once again there's no definitive data to prove this. In terms of clinical use in diabetic feet, it may improve the healing and decrease the need for secondary amputations in patients with diabetic ulcers. And despite its wide use in pressure ulcers, there's actually very few trials to demonstrate its effect. It's commonly used in open abdomens to help temporize and definitively close wounds, and it has been shown in chest wounds to not only decrease the number of days to closure, but also reduce the size and number of flaps required to close this wound. In terms of skin grafts and wound bed preparations, there's small studies to show increased graft take using these negative pressure wound therapy dressings. There are a few warnings about 6 deaths in 2010-2011, mainly in patients who are at home facilities or long-term care facilities. And most of the injuries that's been reported in the US has been related to bleeding and infection, so care should be used in patients who are at risk of these things.
Yeah, in summary, this was an excellent review of the sort of current state of play with respect to basic research into negative pressure wound therapy, and it offers a good basis on which we can continue to use this modality for the benefit of our patients. The second paper we did was an Australian paper, the anatomical angiosome and clinical territories of cutaneous perforating arteries, development of the concept and designing safe flaps, by Professor Ian Taylor from Melbourne, and this was published in 2011 in PRS. The basic issue with this paper was Professor Taylor looking at the current terminologies with respect to perforasomes or perforator angiosomes, and relating that to the research which he's been guiding for the last 20 years or so. So what were the main concepts that Professor Taylor got across with this paper?
So he rehashed a few of the concepts introduced in his 1987 paper. The concept of the angiosome, which is the anatomical territory of a composite block of tissue that's supplied by a source artery, and it's linked together by anastomotic vessels in all directions, which can be either choke vessels with its narrowed lumen or true anastomosis, which is the same caliber lumen. These true anastomoses often accompany cutaneous nerves, or commonly found in muscles and nerve trunks and delayed flaps. Once again, he rehashed the concept of having 40 bilateral territories, which is 80 territories in total, supplying 376 perforasomes, which is an average of 4.7 perforasomes per source artery. In some angiosomes, the cutaneous part of a source artery might only be represented by one vessel, and others may be by multiple. He reintroduced the concept of perforasome, which can also be known as the perforator angiosome or the cutaneous angiosome, which is basically an angiosome that's supplied by a single perforator. He talks then about the clinical territory of a perforasome, which is essentially the territory that's supplied by the perforator plus one adjacent anatomical cutaneous perforated territory, and that is a safe amount of tissue that can be captured on the perforator at a flat base.
And then he talks about those two adjacent perforasomes being joined by choke vessels, and you're able to open up the choke vessels to the adjacent perforasome or perforating angiosome. But then if you try to go more than that, there will be a line of ischemia or a line of necrosis which develops at the next level of choke vessels. So then he goes on to explain his theory for how the delay phenomenon works, where the idea is by removing or ligating one of the perforators is that the choke vessels open up in the adjacent to the adjacent angiosomes. Thereby you can capture more than one adjacent territory, and you can actually capture quite a large territory through sequential ligation of the perforators within a particular segment of tissue. He gave the example of the delay of a pedicle tram flap and showed how adjacent angiosomes can be captured through delay. And yeah, that was basically it. I thought it was a pretty fantastic summary of an incredible body of work, and which has greatly advanced our ability to reliably plan and execute various flaps of known and named arteries. Did anyone else have anything to add on that?
No, they talked about the Milton concept and how it can apply to perforasomes, and also how now, these days, perforated flaps are probably going to be the new frontier of reconstructive surgery and plastic surgery.
No worries. Okay, the next paper was another classic, which was the Mechanics of Movement for Rotation Flaps and Local Flap Template by Ahuja from India, and this was published in PRS many years ago. This paper basically describes the geometry of how to plan either a rotation flap or a transposition flap using rotation as the main means of flap migration. You only really need to see the diagrams which are located in the flap, in the paper, and the flap is very well described. This is something that certainly here in New South Wales, all of the trainees are very comfortable with, and they're taught well. In other parts of Australia and other parts of the world, other people probably do the same thing, but may not know that it was Dr. Ahuja who originally described the geometry of the flap rotation. This is something particularly on the scalp, which I use quite commonly, and it gives you a reliable and safe way of planning and executing a flap on the scalp, whether it's a transposition flap with split skin grafting to the secondary defect or a definitive rotation flap with no secondary defect being formed. Okay, the last paper which we went on to is actually a new paper. So it's from this year's PRS, and it's Skin Perfusion and Oxygenation Changes in Radiation Fibrosis, and this is from Boston, Massachusetts, and by Chin et al. So, Al, what in a nutshell was this paper about?
This paper basically is looking into separately what the perfusion of tissue in radiated tissue is, and also the oxygen level of the tissues, which previously had not been looked at separately. So it's a prospective controlled trial in 10 mice using mouse models and bilateral flanks. So they had 20 specimens from irradiated tissue, and this tissue is irradiated at a fixed dose of 50 grays at a depth of 95 microns. And after irradiation, these rats are euthanized 8 weeks later. This is based on a translation model which suggests anything more than 4 weeks equates to chronic irradiation injury.
And each rat had their own control area of non-irradiated skin, which in all the subsequent analysis, which was both immunohistochemistry and polymerase chain reaction, as well as they were the main two things. It's actually counting the number of vessels and the like. They were able to have each patient act as their own control. So what were the main results which they found?
They found that there was increased chronic fibrosis in the papillary dermis, increase in the ratio of the type 1 to type 3 collagen, but there's no difference in the reticular dermis in terms of fibrosis. In terms of perfusion, it peaks at day 14. and by the end of 8 weeks, this significant decrease in the amount of total hemoglobin. They found that oxygenation also peaked at day 14, but it actually returned to baseline by the end of 8 weeks. In terms of vascular changes, there were 43% decrease in the vascular density compared to control. And they found that there is actually no difference in the hypoxic epidermal cell fraction between the irradiated and non-irradiated tissue. The amount of growth factors that's secreted, VEGF, and the receptor expression is significantly decreased.
So what were their conclusions then?
Their conclusion was that irradiated cutaneous tissue is hypoperfused, but it's normoxic. And they postulate that this normal level of oxygen may be due to the lower metabolic requirements of these fibrotic and irradiated tissue, despite the hypoperfusion.
Yeah, it's sort of in many ways a bit difficult for a simple surgeon to get their heads around that there can be decreased blood flow, decreased vessels and vessel diameter, and yet the oxygenation to the tissue appears to be at a normal level. But it's a great model, and hopefully then they can see what factors may influence that in order to better treat the areas of radiation damage. Okay, Alice did a fantastic job with the Journal Club this evening, and for those of you who are there, I hope you enjoyed it, and for those of you who are listening now, thank you for listening. Good night.